Good afternoon, everyone. I'd like to open this session. I'm Masanori Atsuka from Nippon Medical School, Japan. I will be chairing this session together with Professor Grace, but she's not in here. The session is Young Investigators Workshop, APASLAASLD, Cirrhosis2. Today's three presentations will be 10 minutes each and 10 minutes for discussion. The first presenter, was it? Okay. I'd like to introduce Fazit. The first speaker is Dr. Wazit from Thailand. The title of his presentation is Sarcopenia is associated with the risk of minimal hepatic encephalopathy in patients with cirrhosis. So let's get started with your presentation.
Good afternoon, ladies and gentlemen. On behalf of all authors, I'm so honored to present my research at APASL 2024. We have nothing to declare for this study. Sarcopenia is a condition characterized by a reduction in muscle mass and either muscle strength or physical performance. Sarcopenia has gained significance in the evaluation of patients with liver disease. The prevalence of sarcopenia is approximately 30 to 50% in cirrhotic patients. Sarcopenia is found to have a detrimental impact on clinical outcomes in patients with cirrhosis, such as higher mortality and risk of overt hepatic encephalopathy or OHE. Minimal hepatic encephalopathy or MHE is a subtype of hepatic encephalopathy associated with subtle cognitive deficits, such as reduced attention and integrative functions. Prevalence of MHE is about 20 to 25% in cirrhotic patients. MHE negatively influences quality of life and driving skill. It's also associated with higher risk of hepatic decompensation and mortality of cirrhotic patients. It is proposed that reduced muscle mass in sarcopenia may cause reduction of glutamine synthetase activity and lead to accumulation of ammonia level. Hyperammonemia disrupted function of astrocytes and resulted in the development of overt hepatic encephalopathy. However, whether sarcopenia contributes to development of minimal hepatic encephalopathy remains unknown. Therefore, these prospective studies aim to investigate the association between sarcopenia and MHE in Thai patients with cirrhosis. We prospectively enroll adult patients with cirrhosis between April to October 2023 at Liver Clinic in Sirat Hospital, Thailand. We recruited patients without clinical manifestation of OHE according to West Haven criteria. To confirm the absence of OHE, we examined the patient with the mini mental state examination or MMSE. Patients with MMSE score of at least 24 were confirmed to not have OHE and included in our study. Patients with conditions that could influence sarcopenia or MHE are excluded. Exclusion criteria as in display. The example of exclusion criteria are patients with neuropsychiatric conditions such as Parkinson's disease and Alzheimer's disease, patients taking psychoactive medications such as benzodiazepine, patients currently taking lactulose, rifaximin, or BCAA, patients with uncontrollable decompensated comorbidities such as heart failure with NYHA class 3 to 4, end-stage renal disease, and COPD-GOD. All patients were evaluated for detailed clinical and biochemical data for severity of liver disease. Subjects were tested with the validated Thai version of paper pencil-based psychometric hepatic encephalopathy, or PHES, to determine their cognitive functions. PHES is considered a gold standard for diagnosis of MHE. PHES is composed of 5 tests: the number connection test, NCT A and B, the digit symbol test, DST, the serial dotting test, SDT, and the line tracing test, LTT. The score of each test ranged from -3 to +1. The score was graded based on the validated normative values, adjusted for age and educational levels for Thai population. The total score of PHES ranged from -15 to +5. Patients with PHES score of less than -4 were diagnosed with MHE. All patients were tested according to standardized manual instruction. All patients were evaluated for the presence and severity of sarcopenia according to the 2019 criteria by the Asian Working Group for Sarcopenia. Muscle mass is measured with bioelectrical impedance analysis or BIA to measure skeletal muscle index or SMI. SMI is determined by appendicular muscle mass divided by height square. Low muscle mass is defined as SMI less than 7 in men and less than 5.7 in women. Low physical performance is defined as gait speed from 6-meter walk less than 1 meter per second. Low physical strength is defined as hand grip strength, measured by hand grip dynamometry of dominant hands, average for 3 times, less than 20 kg for men, and less than 18 kg for women. Sarcopenia is defined as low muscle mass with either low physical performance or low muscle strength. Severe sarcopenia is defined as low muscle mass with both low physical performance and low muscle strength. We computed odds ratio with 95% confidence interval in unit rate logistic regression analysis. Factors with p-value less than 0.1 in unit rate regression analysis were included in multivariate logistic regression analysis. P-value less than 0.05 was considered statistically significant. 220 cirrhotic patients were screened for MHE. 10 participants were further excluded due to MMSE score less than 24. Remaining 210 patients participated in this study. 57% patients were male. The mean age was 62 years old. 195 patients in child Pew A and 15 patients in child Pew B. The mean male score was 9. Most common etiology of cirrhosis in our study was viral hepatitis. The prevalence of MHE is 17.6%, with prevalence of 16.3% in patients with child Pew A and 33.3% in patients with child Pew B. The prevalence of sarcopenia is 25.7%. The prevalence of severe sarcopenia is 12.3%. MHE group usually had more advanced age and lower education level. Most patients in MHE group had primary school education. They also had higher prevalence of history of hepatic decompensation, such as history of overt hepatic encephalopathy and variceal bleeding. There is no difference in etiology of cirrhosis between two groups. Patients with MHE were more likely to have more severe liver disease index, such as higher total bilirubin, lower albumin, higher globulin, lower platelet, and lower leukocyte. There is no difference in MELD score and Child-Pugh classification between two groups. Moreover, patients with MHE tended to have higher proportion of sarcopenia and severe sarcopenia, reduced muscle mass, lower muscle strength, and physical performance, as reflected by lower skeletal muscle index and hand grip strength and gait speed. Patients with sarcopenia had lower total score of PHES and in all subdomains of PHES, implying worse cognitive functions in sarcopenic group. In univariate regression analysis, MHE was associated with age, education at primary school, sarcopenia, and history of variceal bleeding. In multivariate regression analysis, adjusting for factors with p-value less than 0.1 in univariate analysis show that only age, sarcopenia, and history of OHE and vessel bleeding were associated with presence of MHE. When we substituted severe sarcopenia instead of sarcopenia in both univariate and multivariate analysis, we found that severe sarcopenia was independently associated with MHE, with adjusted odds ratio of 3.64, with 95% confidence interval between 1.32 and 10.05. In conclusion, sarcopenia and MHE are not uncommon among patients with compensated cirrhosis. Sarcopenia and severe sarcopenia are independent risk factors for MHE, regardless of cirrhotic severity. Detection of sarcopenia might help identification of MHE. Intervention for sarcopenia such as nutritional improvement might lead to better quality of life in cirrhotic patients. Thank you.
Thank you for your great presentation, Dr. Wazit. So floor is now open for discussion. Are there any questions? Please.
Thank you for your great presentation. I really enjoyed it. I have a question that, have you done any research on the reverse? I mean, if sarcopenia improves, does minimal hepatic encephalopathy improve or something like that? If sarcopenia improves, does MHE get better or not?
It is a very interesting question. Actually, I think we might need further research about that topic because in my literature review, there's no such data in that topic that if we improve sarcopenia, the MHE will get better. But I agree with you that such intervention to improve the sarcopenia will help improvement of the cognitive function of cirrhosis patient because if we go back to the background of this study, if the muscle mass is reduced, the way to reduce the way to get rid of the ammonia in our body is reduced. So if we can improve the muscle mass, the way to get rid of the ammonia will get better, and so the cognitive function might get better.
Thank you. I'll be looking forward to hearing from you.
Thank you. Any other question? Okay. You report the association between MHE and sarcopenia in patient with cirrhosis, and mentioned MHE is more common in elderly patients with cirrhosis. So is it possible to that dementia is also excluded from this patient?
Yes, this is one of the strengths of our study because neuropsychiatric conditions such as the dementia, Alzheimer, and Parkinson are totally excluded in our study, and we confirm the exclusion of that condition by the minute mental statement examination, the tools that we use to diagnose the dementia. So in this study, we can confirm that dementia is totally excluded because MMSE score of all patients in our study exceeds 24. Okay. And exclude the diagnosis of dementia.
Okay, thank you. Please.
Sorry, just another quick question. Asim from Auckland City Hospital, New Zealand. Congratulations on the great presentation and great research. So in your two groups, it looks like there was a clear difference in the people who had demonstrable portal hypertension in the past with either overt encephalopathy or variceal hemorrhage. Any thoughts on the role of that as a common mediator for both sarcopenia and MHE?
Actually, I think the portal hypertension directly related the severity of liver disease. For example, if we have more severe liver disease, like more stiffness of the liver, is this harder to for the liver to detoxify for detoxification of like bad stuff in our body. So it's reflected in more history of portal-related complications such as vessel bleeding and overhepatic encephalopathy. And when we look at the liver disease index, patients with MHE tended to have a lower number of platelet counts, which directly correlated with portal hypertension.
Right. Yep.
So I think actually like portal hypertension can be a main explanation also for the development of MHE.
Yep. Cool. Thank you.
Besides sarcopenia.
Thanks.
Thank you for the very interesting presentation. So normally the gold standard for skeletal mass index is done with MRI, body composition, or a DEXA scan. Do you have a chance to validate your machines to show that it gives you reproducible readouts?
Actually, for the Asian population, the gold standard for sarcopenia diagnosis can be DEXA scan or CT scan, but due to limited availability of like sarcopenia L3 muscle index, it is proposed that for general population or for cirrhosis patient, BIA bioelectrical impedance can be substitute to diagnose sarcopenia, and in this study we use the BIA for the detection of muscle mass because not all patients with cirrhosis undergo CT scan. Some patients got a screening SCC by the ultrasound, so I think in this study it's more applicable to real practice to diagnose the sarcopenia, because like it is much easier to diagnose the sarcopenia in cirrhosis, no need to further imaging. And actually we have the result from the study in Thailand from Songkhla Nakhrin Hospital. It's proved that hand grip strength and BIA actually directly correlated with the gold standard of sarcopenia with L3 result from CT scan. AURC is very high. It's about 90 to 95% for the detection of sarcopenia.
Right. Yeah. Second question is, were you able to correlate with the serum ammonia with MHE?
Yeah, this is actually at the concept of the study, we would like to collect the ammonia level. But as we all know that collection of ammonia is very difficult because we have to collect the ammonia from arterial blood collection, which can be very distressed and painful experience for all patients. And it's also very difficult to transport to the laboratory. And also ammonia level, if not handled appropriately, the level can be influenced by very several factors. So
last question, a bit complex, but so you have shown a association between sarcopenia and MHE. How do you do the next experiment to find out which direction does it go? Is it sarcopenia causing MHE, or is it MHE and therefore they don't eat as well and therefore they result sarcopenia?
This is thank you for your question. This is the main limitation of our study, because our study is conducted in cross-sectional study, so we cannot firmly establish the causal association between two conditions, whether what comes first. But we plan to further conduct this study. That, for example, we plan to conduct the study that we will bring the patient that we screen at this time do not have the MHE at this time, and we will follow the patient maybe like for a year, and we will perform the PSES again to detect whether they develop MHE in kind of like a cohort study. So we can further establish the causal relationship between two conditions. But in this study, I think sarcopenia can cause a causal relationship to MHE due to like possible biology possibility.
Okay. Any other question? Okay, last question. You excluded the patient using rifaximin and BCA, and my question is, were there any effect on drugs on complication of cirrhosis in this study? For example, it has been reported that loop diuretics worsen sarcopenia. Diuretics?
We do not exclude the use of diuretic in this study. The reason we exclude the use of rifaximin, BCAA, and lactulose in this study because these three agents are proved to improve the overt hepatic encephalopathy. So we believe that the use of these three medications can influence the cognitive function of patients with cirrhosis. So we try to get rid of as many as confounding as possible.
Okay, thank you. Okay. Thank you, Dr. Wajid.
Thank you.
And the second speaker is Charlotte from China. Charlotte. The title of her presentation is Risk Factors of Liver-Related Event in Patients with Type 2 DM. Let's get started with your presentation.
Okay, thanks, moderator, for a kind introduction. And good afternoon, dear professors, doctors, dear colleagues and friends, dear ladies and gentlemen. I'm Charlotte Juan Song, a second-year PhD student from the Chinese University of Hong Kong. And it is my great pleasure to be here in the Young Investigator Workshop today and to share with you something about our project on risk factors of liver-related events in patients with type 2 diabetes mellitus. First, I would like to declare this study was supported by Health and Medical Research Fund of Healthy Bureau of HKSAR government. In recent years, we have all seen the rising prevalence of the non-alcoholic fatty liver disease, NAFLD or MASLD, as well as the advanced fibrosis and cirrhosis among patients with type 2 diabetes mellitus. Apart from the prevalence of metabolic syndrome, other common risk factors, including alcohol use, obesity, also play an important role in the development of liver-related events. Meanwhile, recent years have also seen the increasing trend of youth onset of type 2 DM, along with the rising prevalence of obesity and the evolving strategies for the management of type 2 DM. All of these have made the interplay between the type 2 DM and adverse liver events more complex. So to elucidate the association between diabetes and liver-related burden, as well as to prioritize the screening for those at higher risk for liver disease among patients with diabetes, we performed this study with three main purposes. Well, the first was to estimate the secular trend of liver-related events disease burden among patients with type 2 DM. And the second, which is also the focus of my presentation today, was to identify risk factors associated with the risk of liver-related events, LRE. And the next step involves developing a lasso-based prediction model for the screening purposes. Initially, we included all adult patients with the diagnosis of type 2 diabetes mellitus from the January 2007 to December 2021 in Hong Kong. And after exclusion of those with chronic virus hepatitis, excessive alcohol use, metabolic and autoimmune liver disease, as well as those developed malignancy or liver-related events between their diagnosis of type 2 DM, we included 575,000 patients in our final cohort. Well, the primary endpoint was set at the incident liver-related complications within the follow-up duration. And the liver-related complications definitions include hepatic decomposition, HCC, liver transplantation, and liver-related death. Well, the secondary endpoint included the non-liver-related mortality within the follow-up duration. From the flowchart in the stats, we can say that our patients at a median follow-up duration of 6.2 years were diagnosed at the mean age of 61.9 years old, with 52.3% being males. And the incidence rate of the liver-related events was 1.279 cases per 1,000 person-years at risk. We then perform univariable and multivariable regression analysis to investigate the association between the diabetes and liver-related events, as well as to do the variable selection for our next step, predictive model construction. And we also do the population attributable fraction analysis to better understand the risk estimated by each factors. So based on the primary analysis from the univariable fine-grained competing results regression model, we found that the advanced age, male gender, presence of compensated cirrhosis, hypertension, as well as baseline use of sulfonylureas and insulin were all associated with an increased risk of liver-related events. However, some of the non-significant variables in the univariable analysis turned out to be significantly associated with the risk of liver-related events by multivariable cause-specific competing analysis. For instance, higher body mass index was actually associated with increased risk of liver-related events, while the effect of insulin on liver-related events were reversed with a less than 1 subdistribution hazard ratio. And this impact and this seemingly protective effect of insulin on LRE can be actually largely attributable to the survival bias. That is, the patients receiving insulin therapy initially may have poor glucose control and may be more likely to experience non-liver-related mortality earlier. So this may, and this is also reflected by their greater than 1 subdistribution hazard ratio of insulin for competing death analysis. So this is the reason why the manifestation of liver-related events were hindered. Oh, sorry. And all these results have provided some insights for the management of patients with type 2 DM. And those with diabetes and cirrhosis, even still in the compensated stage, still need heightened clinical attention and closer monitoring on their liver function. Additionally, we also observed a nonlinear association between hemoglobin A1C and the risk of liver disease. And based on this U-shaped curve from the restricted cubic span analysis, we found that the hemoglobin A1C contributed to the liver-related risks much more significantly for extreme levels when the hemoglobin A1C were distributed at two ends, compared to the relatively normal range of the parameter in the middle of the curve. And that's also provides some considerations for the management of type 2 DM, indicating that we should not only focus on those with poorly controlled high blood sugar, but also need to exercise extra caution on those who are prone to hypoglycemia, since the hypoglycemic condition may also pose heightened hazards to the patient's liver function and health. Finally, we also performed the population attributable fraction analysis for liver-related events and non-liver-related mortality. And among all covariates, you can find the advanced age explain most about the incidence of both liver-related events and non-liver-related mortality, followed by the compensated cirrhosis in the liver-related mortality, but calcium channel blocker use for non-liver-related mortality. However, compensated cirrhosis still contributed to about 5.2% risk of non-liver-related death in type 2 DM. This finding also highlights the importance of the complex interplay between the diabetes and liver. And this finding suggests that those with the coexistence of the two conditions, these patients may significantly increase the risk of higher subsequent poor prognosis, whether from liver-related or non-liver-related complications. And this is also in accordance with most previous findings that cardiovascular events remain the top cause for the mortality among patients with NAFLD. So ladies and gentlemen, please allow me to emphasize the importance of the following points again. Advanced age, male gender, presence of compensated cirrhosis, higher BMI, increased creatinine and baseline use of sulfonylureas were all associated with increased risk of liver-related events among patients with type 2DM. And a nonlinear association between the hemoglobin A1C and the LRE was observed. Advanced age was the most important risk factor for development of liver-related events, and the compensated cirrhosis significantly contributes to liver-related events, and to a lesser extent to non-liver-related mortality. Our recent work updates involves passing the variable lactate by multivariable analysis to the lasso regression methods to build a more refined and predictive model for validation. And thanks again for your presence and listening to my talk here, and any comments and advice will be greatly appreciated. Thank you.
Thank you for your excellent presentation, Dr. Charlotte. Are there any questions?
Congratulations on your great presentation. I'm Dr. Pruksa from Chulalongkorn University, Thailand. So I have two questions. The first one, there's more data that patients with MAFO and have F2 or significant fibrosis is related with mortalities. So do you have the data about significant fibrosis or any non-invasive tests that show relations with survival in patients with type 2 DM? And the second question is pioglitazone and like GLP-1 agonist is a treatment of choice and have many studies in patients with fatty liver. So do you have the data specified to this medication? Thank you.
Okay, sorry for your first question. Can you please repeat it? I didn't catch it very clearly.
Okay, so do you have the like non-invasive test or TE or fibrosis score that show about like significant fibrosis related to mortalities or survival in patients with type 2 DM from your study?
Okay, we do calculate the non-invasive fibrosis of FIB4 and APRI for the I got the initial inference model, but we didn't associate its relationship with the mortality, since we consider that many parameters included in our study will have certain missing, and because this is such large cohort, and we use some single imputation to compensate for that. And after that, we think the FIB4 and APRI based on that may not accurately reflect the liver function or status of our patients at baseline. So we just use that for the observative purpose. Thank you.
The second question is, some medication used to treat fatty liver, for example, pioglitazone or GLP-1 agonist. Do you have data about that medications?
Yes, we do. We do include other categories of anti-diabetic medication, but after multivariable analysis, some anti-diabetic medications may be due to the relatively limited usage within our cohort. They were proved to be non-significant, and I already put all significant variables with the outcome of interest in the slides, so others may be non-significantly. Thank you.
Any other question? Okay, please.
Thank you for your presentation. I was very intrigued with the HbA1c J curve. So the idea that low HbA1c is also detrimental, was there evidence of hypoglycemia and so on to support the biology why patients were doing badly with low HbA1c?
Sorry, may I confirm that you asked the reason for the low hemoglobin A1C contribute to the risk? Okay, I think we have discussed about that point, and that is a very important question. I think the main reason why the low hemoglobin A1C associated with the significant higher liver-related events, due to their overall bad condition, because when the blood glucose was lower than the normal range, like before 5 or 4, the patient's overall body condition is not so good, and that's can be associated with significantly not only liver-related mortality, but also other non-liver-related events, like cardiovascular events or the higher mortality, etc. So I think that's that is mainly due to the status. The patient status was not so well in that case. Thank you.
The second question is on the finding of compensated cirrhosis as one of the predictor. How was this established, by ultrasound for our patients, or do they receive a protocol fibroscan for in the clinical practice?
You mean our definition for the compensated cirrhosis?
Yeah.
We mainly define the compensated cirrhosis with the diagnosis codes. We adopt the SAD9 code from our electronic patient health system to differentiate those with the liver-related symptoms of different severity.
Right. Last question on the Lasso analysis, where you put the factors together. Is this translatable into a clinical score that can be used to predict high-risk patients?
We have been considering that, but we are not very certain about the practical value of the risk score developed. As you can see, there are many risk scores nowadays, and if we can truly apply that into the clinical practice, it remains a question. But we do build such model, and I would like to say its discrimination and calibration value to be optimal enough, and to determine such an optimal model, and then to consider next step of the practical risk score application. Thanks for the question.
Okay, please.
Thank you for your informative speech. Leita Shakian from Armenia. You discussed about the relationship of liver cirrhosis and type 2 DM. And what about the treatment options? How you think when we improving the liver's function, it is possible to include the type 2 DP treatment option this care?
Yes, you mean the treatment of the anti-diabetic drugs can have a certain...
And including the, for example, hepatoprotective drugs in these diseases or treatment options, for example. How do you think about that?
Yes, may I confirm that you mean the use of anti-diabetic medication may generate some bias on the relationship reflected by the analysis? Yes, that's an important question, and we also consider the potential impact on the anti-diabetic medication. But for instance, our next step of Lasso prediction model construction, we just remove those anti-diabetic medication because we think the medication use will depend on many factors we cannot control. Like it can largely dependent on doctors' subjective opinion and also the patient's conditions development. So for the prediction purpose, we exclude those medication impact. But for now, it's just a multivariable analysis, and we would like to observe and to investigate the concrete risk factors associated with that specific liver-related events. So we would like to include them. But we also perform the additional analysis like time-dependent analysis, which also consider the time of the anti-diabetic medication use into the analysis and to model the change of the medication as well as to analyze their impact on the liver-related events. So the time-dependent, according to a time-dependent analysis, we also have some novel findings like the insulin impact, as I mentioned just now. Its effect on the liver-related events was reversed again, and just over the one again. And we guess the time-dependent analysis can more objectively reflect the antidiabetic medication impact. But for prediction, we just remove them.
Thank you.
Thank you for question.
Thank you. May I ask a last question?
Okay, thank you.
According to your presentation, liver-related events were defined as both the development of HCC and decompensation, right?
Yes,
Okay,
both was defined as the primary outcome.
So my question is, what factors were associated with development of HCC?
Oh yeah, thanks for your question. That's an important point because I also found some study. They will investigate the risk factors associated with HCC alone. But I'm regret to say that our project only combine those as a composite endpoint of both liver-related events and HCC, and to define them as our primary outcome and to observe this development. But we do think this has it has certain value since many liver-related events, as long as it's severe enough, may have a large likelihood to develop into the HCC. Yeah, but currently we have not do the separate analysis for this subgroup, but we may consider it for our.
Okay,
yeah.
Thank you. Okay, any other question? Okay, thank you, Dr. Charlotte.
Okay, thank you again.
So I'd like to introduce last speaker. The last presenter is Andrei from Romania. The title of his presentation is a prospective study of cardiohemodynamic profile change in acutely decompensated cirrhosis and ACLF. So let's get started with your presentation.
Thank you very much for the opportunity of presenting our results to you here in this competitive workshop and in the beautiful city of Kyoto. These are my disclosures. Now, I'm going to repeat this several times throughout the presentation. This was an exploratory cohort study, so of course we started with things that we did know, tried to find out things that we did not know, but along the way also found out there were things we didn't even know we didn't know. So let's start with what we did know. We know that cirrhosis isn't just a single organ failure, it is a multi-system syndrome. We know that it does affect the heart, that cardiac dysfunction is prevalent in cirrhosis, up to 40% in stable patients. There is even an entity that has been termed cirrhotic cardiomyopathy, which is defined by echocardiographic evidence of systolic and or diastolic dysfunctions in the absence of known heart disease. We know that acute on chronic liver failure is highly dynamic, that it is driven by inflammation, and that it includes a circulatory component, which is of course the mean arterial pressure. And recently it has been shown that hyperdynamic cardiac patients with cirrhosis are at highest risk for fatal ACLF during short and long-term follow-up. So our group has previously looked at associations between imaging parameters of heart failure, mainly echocardiography, but also MRI. And we have seen that there are associations between these factors and conjugated bile acid levels in stable patients with cirrhosis, that there are indeed associations with markers of fibrosis and inflammatory markers, this in relationship to the extracellular volume determined by MRI in patients with cirrhosis. And recently in a retrospective cohort, we have also found out, surprisingly to us, that patients with cardiac dysfunction defined by echocardiography were actually less likely to die during long-term follow-up, which of course prompted us to consider the questions of what we still do not know. And we still do not know the real prevalence of pure cardiac dysfunction in patients with cirrhosis. We do not know to which extent circulatory dysfunction in acute decompensation of cirrhosis can be attributed to latent heart failure. And unfortunately, there are still questions around the reliable diagnosis of cirrhotic cardiomyopathy. Even though the criteria for diagnosis have recently changed, this is mainly an echocardiographer's game and not a hepatologist's game. So our hypothesis moving forward was that there were links between inflammation, circulation, and the development of ACLF in patients with cirrhosis. We also suspected that the highly dynamic changes seen early on after diagnosis of ACLF could partly be due to rapid changes in the cardiocirculatory system, and consequently expected to find associations between CLIF-C scores, inflammatory markers, echocardiographic parameters, and ultimately patient outcome. So our aims were to explore the cardiocirculatory profile of these patients admitted for acutely decompensated cirrhosis, to investigate any associations between serologic biomarkers and echocardiographic parameters, and to identify cardiocirculatory prognostic markers of negative outcome. And this was our study design. This was again an exploratory prospective cohort study, a single center study that included patients with acute decompensating events and excluded those with history of heart disease or those that we identified with concurrent diseases such as atrial fibrillation. And our outcomes were hard endpoints, 1 and 3 month mortality. And basically, after the screening, the first visit included, of course, the clinical work, blood work, CLIF-C scores. We took serum samples for biomarkers, and we performed an echocardiography within 24 hours. The second visit took place 5 to 7 days later, and we repeated the same protocol. We had another visit at 1 month, and a telephonic follow-up visit at 90 days. So this was our cohort. In the end, for this analysis, we looked at 66 patients with a 59 years mean age. The etiology was mostly alcohol-related cirrhosis. The main type of acute decompensating event was ascites, but of course these were not mutually excluding. 41% of patients had a previous decompensation within the past 3 months. This was the mean MELD score and the child class distribution. Only 9 out of those 66 patients fulfilled the criteria for ACLF with a median score of 46. So this is a table looking at some of the most relevant biologic parameters at day 0, day 5, 7, and at 1 month. And I'll just briefly draw your attention to the mean arterial blood pressure here. Also to the fact that, surprisingly for us, echocardiographically speaking, systolic and diastolic dysfunction were present in very few patients, actually. If you remember, we spoke about up to 40% in stable patients, but we saw a lot less than that in this cohort. No patients with ACLF on admission fulfilled the criteria for cirrhotic cardiomyopathy. And then there was a change in mean arterial pressure from the day 0 to up to 1 week. And we tested this in a paired sample t-test, and it also turned out relevant. So the mean arterial blood pressure goes down in the first week after the admission for decompensating events. Looking at the hard outcomes, we saw that 12% of patients died before 1 month and 24% before the 3 months follow-up. In univariate analysis, death was associated with a decreased mean arterial blood pressure at admission, which was not surprising, with an increased pro-BNP level, which is a marker for heart failure, and with some echocardiographic parameters of left ventricular diastolic dysfunction, another indicative of heart failure. But looking at, so this is the OROC curve, which seems pretty good, but looking at the multivariable analysis, and of course this is questionable because we have very few events, but we did this anyway in different models. We saw that mean arterial blood pressure does hold up, and it is the only one that does hold up as a predictor of death during follow-up. As I've said, this was exploratory, so we've also looked at some associations just to guide our way forward, and we did see some negative correlations between mean arterial blood pressure, NT-proBNP, which of course makes sense, and severity scores for cirrhosis. We saw some negative correlations between left ventricular ejection fraction and left atrial volume index, which are again parameters of heart failure, and some correlations between pro-BNP levels and inflammatory markers such as CRP and IL-6. So our limitations are pretty obvious. This was a partial analysis. We still have some pending results for other biomarkers. We had few patients with ACLF in the cohort, so obviously this is not applicable to that particular population. There are the limitations of echocardiography in practice in patients who have large volume ascites, and it is very difficult to always get reliable results, and I'm going to come back to that. And there is a statistical risk here, of course, because this is exploratory in nature. We have multiple hypothesis testing problem and the risk of type 1 error. But our conclusion, nonetheless, was that the prevalence of cirrhotic cardiomyopathy was much lower than expected for sicker patients with acute decompensating events. There are signals that inflammation associates with cardiocirculatory dysfunction, and that mean arterial blood pressure and some echocardiographic parameters of diastolic dysfunction do seem to predict short-term mortality. So our questions after this study are all decompensating events the same for the heart, for the cardiocirculatory system? And we believe the answer is no. Is it perhaps time to move away from echocardiography as the single gold standard modality for diagnosing cirrhotic cardiomyopathy? And we believe the answer to this may be yes. And furthermore, in such studies, we really do see the potential for deep learning in defining clinical entities such as cirrhotic cardiomyopathy. So this was a very recent study that looked at ECG from many patients and has shown that deep learning can indeed identify the existence of cirrhosis based on the ECG of a patient. So this is very exciting moving forward. With that, I thank you for your attention. Gozeichu arigatou gozaimashita.
Thank you for a great presentation, Dr. Andre. Are there any questions? Please.
Very interesting presentation. Could I check in your cohort of patients, did you do a baseline echo to assess whether there was cardiomyopathy before they go into decompensation? And was there dynamic changes with the decompensation?
Thank you. That's an excellent question. So basically, we know a lot of the definition of cirrhotic cardiomyopathy is actually based on stable patients. So what we try to do for the first time, as far as we knew, is look at this definition in the acute setting, patients with acute decompensation. So we started from the baseline, from admission, and that's when we performed the first echocardiography. Of course, we don't have prior echocardiographies from pre-decompensating times for these patients, so we can't actually assess the prevalence. This is one of the points of the study, that perhaps the echocardiography is not necessarily the best way to diagnose this condition. And there's actually been a study that's published, and I think it's going to be presented here as well, looking at patients with sepsis, with circulatory failure, that defined cirrhotic cardiomyopathy in that group of very much sicker patients than the ones in this cohort. And it would be interesting to ask the presenter why they thought that the definition of cirrhotic cardiomyopathy could apply to patients that came with severe sepsis and obvious circulatory failure.
So indeed, related to your answers, one of the concerns when a patient is decompensated, there's a sepsis on board, there is cytokines and so on, so the circulatory disruption is down. How do you control for a steady state for you to do that assessment? Were the patients not septic, or did you exclude components like this which may confound your analysis?
So again, that's a very good point. One of the ways in which we tried to do this was to have an echocardiography done at 1 month after the event, when the patients who survived were stable. So we do have a sort of comparison after the fact for those patients. So that was one of the ways in which we can do that. And we are currently moving forward with an extension of the study, looking at stable patients without prior decompensating events and trying to follow them up longitudinally and see how that echocardiography changes, if it does.
Okay, any other question? Okay, let me ask a question. Does the decreasing mean blood pressure reflect the effective circulating plasma volume in these patients?
It's a very good question, and it's a very complex question to answer properly with what we had. So we do notice this decrease in blood pressure after 1 week after the admission, and it may be due to reduced plasma volume. These patients, of course, received standard care, so that might involve fluid shifts from extracellular space, so that is a possibility, and we try to look at that as a confounder.
Okay, thank you.
Thank you.
How about CV? Okay. Okay, any other question? Okay, thank you, Dr. Andre. So I'd like to close this session. I'm excited to chat with them about our topic today. And thank you for coming to Kyoto today. Thank you.